Welcome, everybody, to our second Behavioural and Implementation Science intervention webinar hosted by the National University of Singapore. I really appreciate those of you in Singapore that are logging on. We are aware it is very early in the morning your time, and with some homeschooling given the current semi-lockdown over there, I hope you're able to stay with us the whole time. Otherwise, this is being recorded for people to join later on. The focus of our second webinar today is around innovation in the use of behavioural and implementation science, with a particular focus on mental health. And I have three fabulous panelists to join you for the next hour. I'm going to introduce each of these folks briefly, and then we'll start moving. So firstly, Dr. Joanna Moullin. Joanna is a senior lecturer in implementation science in the Faculty of Health Sciences at Curtin University in Perth in Western Australia. She completed her PhD in Australia, went over to Spain, and then did a postdoc with a good colleague of a number of ours, Professor Greg Ahrens, focusing on implementation science. So welcome, Joanna. Our second is Professor Aaron Lyon. Aaron is a professor at the University of Washington Department of Psychiatry and Behavioral Sciences and a licensed clinical child psychologist. He directs too many centers for me to name because it will take quite a while. So hopefully, as Aaron shares with us a little bit about his work, he can handle the various acronyms. If anybody ever needs to get a very cool acronym for a new center, Aaron is your guy. And finally, but certainly not least, Associate Professor Swapna Verma. Swapna is completed her residency training in the psychiatry at Baylor College of Medicine at Houston, Texas in the US, and is a registered psychiatrist. She is currently based in Singapore, working with the Institute of Mental Health, and I hope I got that right. Yes, I did, and chairman of the medical board over there. So welcome, and appreciate you joining us very much so early your time. And Joanna, being in Perth, of course, is nice and early. So again, so thank you to our three speakers. I'm going to start by asking Joanne to talk briefly about some recent experiences you've had in the use of behavioural and implementation science that made quite a contribution in the area of mental health or a similar area in terms of being able to bridge the evidence to practice gap.
Okay, thank you, Robyn. And congratulations to you and your colleagues on the launch of this institute and the invitation to be part of this panel. It's really exciting to see the emerging interest in implementation science in Singapore, but also as we have people logging in everywhere as it's sort of blossoming, I would say, implementation science. I think it's important to note that implementation science has a strong foundation in mental health, but that's particularly the case, I think, in America, where they sort of launched the Society for Implementation Research Collaboration, CIRC there, and recently the journal, Implementation Research and Practice, which has a focus on mental health and addiction, or behavioural health, as they like to call it. But I will leave Aaron to sort of speak about the situation developments in the US and the trends in the literature, but I think they're really at the forefront of that side of things in mental health space, because they've been working on that for a long time now. I do see personally one of the things that is sort of growing particularly at the moment is addressing equity issues with mental health over there. But as I say, I'll leave that to Aaron. I think he knows more about that. Here in Australia, I think we're at a different point along the implementation science journey, and I think the application is not quite at that stage. I'd say we're almost at the earliest days of implementation science, where it's gaining a lot of attention. And I'm sort of seeing the term littered across funding calls and organisations' sort of strategic plans, even developing implementation frameworks for their projects. But I'm not necessarily seeing that sort of going, it's still then being applied beyond that in some cases. So what I've sort of seen is we're getting calls at this stage for implementation evaluations of where evidence-based practices are that have been sort of put into policies in the past. And so I hopefully, we'll see that further, introduce implementation science earlier in the journey, whereas I'm sort of seeing it at that point now. So it's more the interest in it rather than its current application that is where I'm seeing it's at. we are seeing implementation projects, I would sort of call them, rather than implementation science studies. So people are using the term implementation and they are implementing. It's not sort of an incorrect use of the term, but we still have that definition issue where people can sort of say it's an implementation project. But I think it would be fantastic to see more of the theories and the methods and the outcomes put into those projects so that we can actually sort of systematically study them and, you know, to develop the field of implementation science, and obviously then also to develop the implementation of practices into the mental health space. And I think why that's the case is partly, you know, a gap in knowledge around implementation science, and that's because of a capacity issue. So a capacity issue with people who have studied it, or, you know, they're starting to do short courses, but we could obviously have more of them, as we've sort of spoken about here, to develop the field, to be able to help the sector move forward. But there's also obviously a huge issue in the mental health space around capacity themselves, as, you know, the system and providers that, you know, with particularly post-COVID or during COVID still here, there's such a pressure on the mental health sector. And I think, you know, there's an issue for them to be able to sort of develop these new skills when they're really struggling because we don't have enough people in both spaces. So I'll leave it there for now. I'm
going to come back to you on a couple good points you raised there. Something about the increase of implementation evaluations, and I'd be interested in talking about what's the difference, like what's that compared to an evaluation, what's the benefit? A few other little nuggets you gave us there, but I'm going to go over to Aaron there. And again, tell us a little bit about some of the experiences you've had where you've really seen behavioural and implementation science make a difference in terms of the effectiveness of mental health interventions, or maybe where there's been gaps.
Sure, thank you. It's great to be here. It's also great to go second because I had some ideas, but then hearing Joe talk, I have even more ideas. So I appreciate that, Joe. Thanks. I mean, in the States, I don't think we probably have anything I would call, you know, a mature field of implementation science, but maybe we're on our way there, although I'm not quite sure what a mature field of implementation science actually looks like, you know, and maybe ultimately it stifles innovation. I don't know. I also appreciate the shout out to CERC's flagship journal, Implementation, Research and Practice, an international journal focused on mental and behavioral health, as we like to say in the States, implementation. And we welcome international submissions to the journal led by Kara Lewis and Sonia Schoenwald. I think some of the things that I've seen that I think really reflect implementation successes are some of these long-standing programs of research or programs of research spanning multiple organizations here in the States that have been ongoing for a very long time. Some of the work within our VA system, the Department of Veterans Affairs, has, I think, demonstrated how when systems are large and well aligned, there can be some advances in terms of things like integrated care, integrating mental health services into primary care types of settings. One of the things that I tend to do a lot of is integrating mental health care into what, at least in the States, winds up being the most common service delivery setting for children and adolescents, and that's schools, where we have studies documenting that 50 to 80% of kids who get mental health services in the States get them in schools. So some of the work that I've seen that has effectively brought to larger scale, both prevention and intervention services focused on mental health has been pretty exciting to see. One of the things specifically within the mental health space that I think has been a nice point of innovation and opportunity, and I think the extent to which it's going to ultimately bear fruit is still sort of emerging, has been some of the work funded by our National Institute of Mental Health through what they call their Alacrity mechanism. It's a center grant mechanism. I'm co-director of one of these funded centers that focuses on integrating human-centered design and implementation science. That's our particular Alacrity Center focus. But most of these centers are focused on blending different fields in order to achieve things that are implementation or health services, mental health services goals. Another example of an Alacrity Center has been one that's co-led by Renad Betis that really focuses on behavioral economics. And I think that it's these kinds of sort of interdisciplinary collaborations for the purpose of increasing the accessibility and quality of mental health services that really get me excited. I think within the implementation space, we're pretty prone to grabbing sort of what seems useful and appealing and innovative from other fields. And in a lot of ways, these centers are no exception. And to be able to both sort of learn from and contribute to other fields that may sit on the outside of mental health and mental health services has been really exciting. And through that, I mean, one of the things that I'm most focused on is trying to design more implementable interventions and more implementable implementation strategies, right? That's a lot of implementation there. Implementable implementation strategies. But some of the strategies
maybe some would say too many.
Right? Some may. And yet, we have a lot of implementation strategies that grow and become bulky and could be really well streamlined in order to really have an efficient and pragmatic effect. There's actually another Alacrity Center led by Kara Lewis and Shannon Dorsey that was recently awarded that's really looking at the mechanisms of implementation processes, all with the goal of figuring out whether we can take some of these implementation strategies that we have and make them more efficient by understanding the processes through which they work.
Very nice. I'm definitely also coming back to you on a few things, including implementable interventions. It's some work that we're focusing on in Singapore. I want to prompt people. The Q&A channel is open, question and answer. Please post your questions as you go. I can see a couple coming up now. I will definitely heavily engage there and throw some of your questions at the panelists. So anytime you want to post away. Swapna, please, over to you. In terms of just listening to what Joe and Aaron were saying, and also your experiences on the ground and real life kind of policy development and implementing interventions and the use of even sort of nudge behavioural strategies and implementation. Just give us your thoughts from a Singapore perspective and your position there.
Yeah, sure, Robyn. Thanks for inviting me because implementation science is very, very new to me. But what I am is a clinician at heart and also in the public health space. And I think without my experience, really, without knowing that this is implementation science is, 20 years ago when we started early psychosis intervention program in Singapore, EPIP for short. And it was through a pilot funding from the Ministry of Health. And again, we had seen some of the evidence coming out of Australia, UK, Canada about the effectiveness of early psychosis intervention because for young people, having their first episode of psychosis, and if it was not handled well, there was disengagement with the service and long-term disability. And as you said, I work at the Institute of Mental Health, where we see a large population of patients with chronic conditions. And in fact, we have 1,000 beds for institutionalized care. So we really thought that we needed to push the envelope to early intervention. And that's when we started on this. And it was new. It was a new thing for Singapore to go into community. To do a lot of health promotion, destigmatization campaigns at that time. And I think we looked at the evidence which was coming from the Western countries, but we had to adapt it to Singapore because there are different cultural differences. We had to engage various stakeholders, not only our funding bodies, but the stakeholders, the young people themselves, the various social agencies, the schools, the universities. And then we put the program together, which was really rooted in evidence. We put processes in place as well. So I think all that helped us. And it's constantly improved. Like, it's been 20 years now, and the program is very well established. But I think the whole culture of constantly innovating, looking at data to drive improvements throughout. So, and a lot of engagement of key stakeholders, which are the young people, the patients and families, that drive us to kind of constantly innovate and improve our services. I think that has really helped us sustain these past 20 years and grow, in fact. So from early intervention, the offshoot is really into youth mental health that we went about 10 years ago, because when you're working with young people, you realize that it's not just psychosis. They're struggling with a lot of other issues beyond psychosis: anxiety, depression, stress, eating disorders. And so, and when we kind of were doing focus group discussions with the young people, we realized there were a lot of barriers to seeking help. Not just stigma, but a lot of, confidentiality issues. They were worried about, how having their registration in Institute of Mental Health or Psychiatry would kind of have impact on their future, things like that. So we set up a chat, which is really assessment, mental health check for young people. Anybody could walk in. They did not need to pay. They did not need to register, similar to Headspace in Melbourne. And it's really, we systematically try to reduce barriers to help seeking. And again, so I think a lot of maybe unknowingly we took pages from implementation science and put that in practice.
We would all agree with that, and behavioral science. You just named a whole bunch of strategies that a number of us would throw into trials and test which was more effective or what combination. So I would totally agree with what you're saying. And in fact, there's a question from Sana up here that I'd like to ask you, because it relates to what you were just talking about, Swapna. What and how, and I'll also ask Aaron and Joe to comment on this, because each of them have experience, but what and how how could you include consumers in, I think what the question is, in improving the implementability of mental health services and interventions? Because you talked a lot then about examples of including consumers. Have you got some examples? Because that is a very hot topic in behavioural and implementation science, about the inclusion of consumers and in helping us improve the design of our interventions and our implementation plans, the way Aaron was talking about. If you could comment on that, please.
Yeah, so I think that is critical. So, when during the some of the groups that we used to have for the young people with first episode psychosis, many of them started kind of staying back and volunteering, very informally, and we felt that really helped the other patients. So it started that way, but then we kind of took them in, not just as volunteers, but we used to kind of, by hourly, we used to pay them, and they became a part of the team. And gradually now, in fact, we have all different opportunities for recovered patients with with first episode psychosis, so what we call as lived experience or peer support specialists. And now we have 3 peer support specialists as a part of our team. They are full-time employees, and I think they have really helped elevate the service from just looking at improvement to a recovery-focused model of care. And we couldn't have gone into that without their input.
Terrific. Aaron, I'll throw to you on that one as well. I know it's an interest area, and just sort of reflect on what you heard there or add some more points.
Yeah, absolutely. I do agree that it's completely critical, and there's lots of different ways to go about sort of getting different, service user or stakeholder input of a lot of different sorts, right? Some of it's service recipients, some of it's service providers, and then there's all sorts of, additional stakeholders who are going to be critical, who may be making decisions about, how workflows play out or what gets adopted or how resources are allocated. As it as it relates to sort of the specific interventions that we tend to deal with within mental health services, which more often than not, kind of medications aside, tend to be sort of complex psychosocial interventions that often have a lot of moving parts and are often relatively difficult to learn how to deliver and learn how to deliver well, especially with fidelity, right? Sometimes we almost take a little bit of strange pride in how difficult some of our interventions are to learn. So we've developed some methods for evaluating sort of the degree of implementability of interventions, of things that might be psychotherapies or could be complex prevention programs, things like social-emotional learning curricula in schools and things like that, in order to identify sort of specific usability issues that might be encountered by users either on the service providing or service recipient side of things. I don't know if I can throw it into the chat or not, but I have a link to a paper that talks about one method, not the only way to do it, but just one example of a method in order to gather that kind of information. And that's the sort of thing that we do at the UW Alacrity Center.
Yeah, if you could throw that up or put it in even the Q&A, people can grab it. That'd be, Joe, I'm going to come back to you on that. One of the things about your work that I'm familiar with is the use of implementation frameworks. So if you think about interventions being the what that Swapna and Aaron are talking about, and implementation being the how. And for those new to behavioral and implementation science, these are phased and staged plans, if you like, to help guide any effort to move an intervention to effective implementation. And there are a number of these. And one of the criticisms of behavioral and implementation science, and I'd say more implementation science than behavioral science, who have done a very good job at keeping things simple, implementation science sometimes has done a very good job at making things complicated. And particularly the use of frameworks. And so I'd almost like you to comment a little bit on the usability for services and policymakers on the ground to some of these implementation frameworks, and how you've improved that in some of the work you've done either here or in other places, if you could comment a little bit on that. And what's the benefit of using them, perhaps, that people might have?
Well, that's a different question, but the benefits is, that we can actually then take advantage of those implementation projects that are happening on the ground and really study them in a systematic way. I think that's, one of the real advantages of using a framework is giving some guidance, and then we can sort of generalize across projects a little bit more. And I think there's another question in the chat that sort of links in there where someone's asked around, how important is it to talk to stakeholders about the fact that it's implementation science? I think that sort of links in there. And I don't think it is, because we use this complicated terminology that's not necessarily we need to throw at the stakeholders, whether that's the consumers, policymakers, whoever else we need at the table, which is so important. It's finding the terminology that makes them useful and relatable to those people, because we need them to sort of engage with it. So I think we, as you say, we've created a problem for ourselves. So maybe we then need to step back and not use those terminology and think about what would be appropriate for the person who's sitting, with us. So, it is really important to have the consumers at the table. And as you're saying, and not just in developing the intervention, which is sort of the newest within implementation science sort of space, but also in developing the implementation strategies and being part of that whole process and being sort of part of the conversation right through. And that includes using them helping to decide, frameworks potentially that are useful, but not explaining them in the way that, we would if we were, sitting around at a conference or on a panel as such like this. So I think what's sort of been developed nice is the open science idea. So a lot of these frameworks currently are sort of entering version 2, I would say. Some of the main sort of frameworks are just sort of relaunching. One obviously where that I've used a lot is the EPIS framework, which is the phases: exploration, preparation, implementation and sustainment. And they have a website that has a lot of open resources, so measures that can be used, questionnaires for people to determine what are some of the barriers and enablers in that context that they should develop strategies associated with. But other frameworks are all the same that now have these great resources. The REAIM framework that is widely used, what I was talking about in the evaluation space, although it is broader than that, they would very much wanting people to be aware of. But they're about to, I think next week, have a webinar relaunching of a new version of that. And CIFA the same, so the Consolidated Framework for Implementation Research, again, one that is very widely used and known about. They're trying to update it to keep it sort of relevant to now, sort of, I think, primarily just so that we can include other people in the use of these frameworks and not just the researchers, so that it can be used more broadly with people on the ground doing implementation work. So that would be, the purveyors of certain evidence-based practices or providers themselves.
Yeah, terrific. Thank you. And there's a few other questions related to that, but I'm going to move us a little bit. Obviously, with COVID and the explosion of attention on mental health and the need to move a lot of that online, I want to have each of you respond to this question. There's a growing evidence base supporting the effectiveness of digital mental health. So why aren't they being used to address massive wait lists for mental health and services? Swapna, heads up, I'm coming to you first. Surely that's a key area of applying innovation to address mental health services needs in a responsive way. And I'm going to add something to that because there has been an explosion in the use of digital online interventions for mental health. There also, and it is well documented in the behavioural and implementation science literature, problems with uptake and adherence to these, notoriously, both by clinicians, but also by consumers themselves. So I would invite any of you to comment on each of those two things, but Swapna, I'll take that question to you first.
Yeah, means again, with COVID, there has been a tremendous, uptake in mental health issues in the community, as well as growing awareness. At least in Singapore, every other day there is, a newspaper article talking about mental health of different population. And I think as psychiatrists or psychologists, it's just not enough to meet the needs of the population then. So I think digital mental health is a great tool. And we definitely need to leverage on that. Again, when you talk of digital mental health, there are different aspects, right? So one is the simplest, which we did during COVID was a telehealth. Because we didn't want patients to come to the clinics, we all pivoted to telehealth, and that has worked really well. Patients find it convenient, we find it convenient, and I think that was easy to implement. The other ones are more complex. So then there you have the self-help, the ICBT delivered completely online. And there are, and then you have the AI chatbots like Wiza or WooBot. So there are different plethora. It's difficult sometimes to choose, even for the users, which one. When we spoke to young people about this, so they definitely feel that that's the way to go. But at the end of it, for them, it is the content and how it is run, and whether it kind of really helps them with their issues. So I think developing these without understanding the needs, co-creating it with the young people, I think then it doesn't work. So then you can have multiple apps, but what they show is that those apps, they just log in and then it fizzles out. Yeah, so I think that is important. And so whichever, I think it has to be done well and ethically created, and there are certain guidelines that need to be used, otherwise it wouldn't work, and worse, it may be damaging.
Yeah, terrific. Agree totally. Aaron, have you got some thoughts on that?
Yeah, absolutely. I mean, I do certainly agree. Some of it comes down to the design, of course, of the digital innovation. As we have sort of more and more of the spectrum of what I would sort of call technology-enabled services, right? Some of which range across the spectrum between those things that might be fully sort of independent digital technologies that are maybe prescribed by a service provider, all the way up to an actual sort of relatively traditional mental health service interaction with a person that has some sort of support from a digital technology or digital innovation of one sort or another. And regardless of where something might fall along that spectrum, digital tools can suffer from the same, and do suffer from the same types of implementation challenges that sort of our more traditional social psychotherapy kinds of interventions tend to suffer from. And there's a lot of different ways to kind of conceptualize, though, what some of the differences might be in the way we're thinking about their dissemination and implementation. There's, of course, sort of like an information and knowledge availability issue surrounding things like apps, but then there are some great resources like the Cyber Guide that Stephen Schuler launched that provides a review and assessment of different mental health-oriented apps. There's ways to consider the design of the technology, the design of the human service component, and the design of the implementation and sustainment strategies, and ultimately considering how they're all put together, their usability and how they're going to fit to context is going to be really important. And then I think there have been some papers that have come out over the last few years that have really tried to take on how do we conceptualize, how do we think about, how do we identify implementation strategies that are going to be specific to some of these digital technologies that we're seeing more and more within mental health, as well as how do we conceptualize or reconceptualize some of our implementation outcomes from a sort of research perspective. When we're often thinking about implementation outcomes, how are we thinking about adoption? How are we thinking about fidelity and sustainment and things like that? When we're talking about some of these digital technologies that open some doors and reduce some barriers in terms of the extent to which they can go direct to consumer, we often need to think about in different ways how we're conceptualizing our implementation outcomes when there isn't always that mediating traditional service provider in between. When we're going directly to consumer and we're looking at really consumer adoption. And I think that the space is sort of wide open in terms of how we're going to conceptualize and ultimately solve those kinds of problems.
Yeah, absolutely. Jo?
I think it's interesting mentioning like the Cyber Guide, or there's probably other ones out there as well, that are sort of evaluating the huge number of these digital mental health applications now. But I think one of the issues is what I sort of said at the beginning is around the capacity of the mental health providers to even go on there and sort of to pick up which ones to recommend to their patients. So I think there is the ones that are going direct to consumers, and there is but the Black Dog Institute does have a sort of program with primary care providers called the Stepped Care. So, where people are mild, they can be recommended, or the consumers can directly go to particular digital mental health sort of solutions or, programs. Moderate, there's different ones. And then there's severe where the face-to-face is something that's, more critical. So I think there's those kind of ideas, but there is the huge issue of still the capacity of primary care in that earlier phase to know about this space, to know, which ones, and do they just take on one, out of, the thousands that are out there that they recommend. So I think that's, something that's really important to note. And I think also from the first webinar of this sort of series was around that also digital solutions are only sort of appropriate for particular people, or that they're only sort of suit, due to sort of things like equity issues. They can create their own sort of problems. But I think the fact that there is so many now, that is starting to be, there's solutions in that space, that there's so many available, but it's how do people sort of navigate that very complex environment to work out which ones to sort of take on. And that's where the implementations, hopefully we can help in, is to sort of come up with strategies for that. I'm thinking primarily because I've been more in the primary care sort of space than the sort of hospital space in this regard, but to help them to implement the digital mental health solutions with their patients.
I'm going to come to you in a second, Aaron's got his hand up. Swapna, I saw you nodding your head a lot. Was there something you wanted to add? Something that Jo seemed to say resonated quite a bit with. Would you just want to throw an extra comment in there? It was the vigorous nodding of the head that got my attention.
No, I completely agreed with what the speaker said. Yeah.
Yeah, very good. Aaron, you wanted to add?
I mean, I think one thing, there's sort of in this modern era of ours, even before we were all on Zoom all the time, there's a sort of pull toward a digital solution for a lot of things. And that's often well and good. But one of the things we try to think about at the UW Alacrity Center is to be sort of strategic about when we're using a digital solution and when we're using sort of a sometimes more accessible and sometimes less bottlenecked analog solution. Because we can always digitize things, and sometimes it solves a problem, but sometimes it creates additional ones. And I think anyone who's probably ever tried to develop an app knows that it's a long timeline in order to get that app done. And by the time you even get it out there, it's very much shortly thereafter, it's going to be in need of an update and a refresh. And it's an expensive endeavor. So I'm a big fan of digital technologies in mental health, and a big fan of sometimes using digital technology judiciously in order to make sure that we aren't sometimes creating additional bottlenecks or access barriers.
There are, I'm just saying this to the team behind the scenes, a number of the questions that I'm trying to monitor on the side, and I can tell you there are a lot of questions on this webinar, which I thank the audience for very much. They're clearly very engaged. There's a few themes of questions around wanting to know more about frameworks that were mentioned. Where can they find a little bit? If I just ask the team behind the scenes to collect those questions, we can easily direct people. Joanna, they're asking where EPIS is, and we don't need to do that live, but I appreciate people's absolute interest in some of the frameworks there, and we can easily provide that to you after the webinar. Something that I know is dear to Professor Lyon's heart, and I think something that might be a good uniting question for us here is, this was the first question that was asked today, is what is the difference between implementation practitioner and implementation researcher? And I get asked that a lot myself, and I think as BISI grows and tries to contribute to the system in Singapore, I just would like a couple of thoughts from you, Aaron. Joe, from you as well. I know you both work with practitioners and as a researcher, and Swapna, I have a particular question I'm going to ask you related to how they answer. So Aaron, please go ahead.
So I think it's the sort of thing where there are fewer differences than similarities. And I think that for the most part, implementation researchers and implementation practitioners, or people who happen to be wearing those hats at a given moment, have the same kinds of goals. And it's usually increasing the accessibility and quality of services for people who might ordinarily be getting less accessible or not being able to access services or lower quality services. And I think that the ways of going about it just shift a little bit in terms of perspective and the primary objective of a given initiative or project. And it really just comes down to, I think, the extent to which a project is first and foremost intended to produce generalizable knowledge versus sort of local impact. And of course, I think often there's projects that are trying to do both, and it's a matter of balance, relative balance. I do think that we continue to be in a little bit of a danger as a field of implementation to see a bit of a gap, and a very ironic gap, between implementation research and implementation practice, where in some ways we're sort of inadvertently recreating the intervention science or intervention research and intervention practice gap that we've all set out to avoid or to address. And I think that we can get past it, and we don't have to fall into that trap forever, especially if we remain conscious of the different parts of our field and how they can be incredibly complementary.
Yeah. Joe, is it your experience as well? There's a bit of a gap growing, and or what's your thoughts on that?
Yeah, and I agree with Aaron pretty much on that sort of topic. I think the easiest with implementation practitioner is hopefully every service provider is an implementation practitioner, meaning they're trying to implement evidence-based practices or evidence as it comes, as it sort of occurs. So I think that's sort of the easiest way to think of an implementation practitioner. Ideally, it would mean they were also applying what's been sort of come about as implementation evidence through implementation research. So that's sort of, the distinction, I guess, or the clarification on there. There is also the term that comes out as implementation sort of purveyor or intermediary, where people are helping the implementation of something get put into practice. So they're the people that sort of help facilitate the process. So there's another sort of term that's sort of thrown around that's also maybe useful to clarify in there. So I think of implementation practitioners as often the providers or the end users to some degree. You've got the patients, but the person providing the practice, which ideally is using some of the theories strategies that have come from implementation science and the evaluations to make that process more efficient, of getting that into practice. And then the implementation research is the ones really sort of studying that. So hopefully, the practitioners are also interested in how many people they're reaching and how many people are taking that up, but that might not be their primary focus, whereas the implementation researchers, their primary focus is on that side of things.
Yeah, and I'm going to just have a reflection, and then Swapna, I'm going to take a question to you. But arguably, behavioural science has done a better job at integrating with science and practice over the years, and implementation science, I think, has a lot to learn from behavioural science and behavioural economics in terms of simplicity and lowest, simplest solutions. So that I think may help decrease that gap. Related to that, and to your point, Jo, that people doing the implementation are implementation practitioners to a certain extent who could draw on the science of behavior change and implementation science to superpower what they're doing, which is, again, the goal of the work that we're all doing globally. Swapna, there's a question here. How much do you think institutional or traditional approaches to introducing new practices, so this is something you and I talked a little bit on the phone about, large-scale standalone training or train and forget strategies, so just train everybody and just kind of hope it all happens. How are these traditional ways of doing things, and I'm not just talking Singapore, I'm talking that would be the same in a number of countries around the world. Are they inhibiting effective implementation, do you think, in mental health? And could you see that there are other things that we could be doing, which again is a bit of a loaded question because that's where behavioural and implementation science comes in, but just talk to your experiences about that from the position you're in at Institute of Mental Health.
So again, I think during COVID, as I said, there's so much awareness of mental health issues, and we are getting a lot of requests from many people in the community that, we want to do our part, which is really good, that everybody wants to do something in mental health. And then they're turning to us that, can you train us? Can you train us? Provide that training. But again, training for what? Like, what does that training lead to? And sometimes it's not always, it doesn't work that way. So again, when we go into the community, especially I think community mental health or at a population level, putting some things without getting the needs and gaps and understanding the needs and gaps analysis on the ground or engaging stakeholders, I feel doesn't work. So that is critical. I think in mental health, we've always looked at, as Aaron said, not only the biological, but the psychosocial aspects of care. And that's why there has been an integration of health and social services fairly, we work closely. But even then, the social services are very different. And if we have to do the training, or if we want to do population health, where you have that integration, we need to understand, come from their side and try to understand where they're coming from. Otherwise, because again, we get a lot of requests for training, but their whole area is very different. Social agencies, the way they work, it's different. And if we just go and train, it doesn't work. It would fail.
Well, given that, I'm going to draw on the knowledge of Jo and Aaron here. So if training by itself isn't a solution, it's probably necessary but insufficient. I know both of you know a lot about the research and practice in this area. If you could comment in a really practical sense, what other strategies you know from the literature has been effective, and or where is the innovation coming in this area? So Jo, I'll start with you and then I'll go to Aaron. What else should we be doing?
Wow, depends on the context, depends on the intervention. It's never the sort of the one size fits all. And I think that's what people always ask for, isn't it? So your implementation, what's the framework and what strategy, you know, without knowing anything else. So I think basically though is that you will need more, that, you know, people to change. If it was just talking behavioural health, just their behaviour, it requires more. But then if you're thinking it might involve also changing their workflow or something around their team or their organisation, potentially even system level, you're going to need much more. And so I think that's one of the differences with behavioural and implementation science, and where they are both needed, is that implementation is possibly a little bit broader, including the change that's required across multiple levels. And if we're thinking of change across multiple levels, we're going to need more strategies than training alone, which might address, even in behavioural, it's not going to address that, it's just addressing knowledge. So it's thinking about what are the barriers to whichever practice you're trying to put into place to work out what strategies are required for that. But it's going to require at least things over time to start with. So if it was training as a one-off, that's, you know, sort of not worst case scenario, but really, you know, you're going to need something else, at least some follow-up sort of training to keep it at people's forefront of minds when they try to put it into practice and it drops off the radar because of everything else that they're being inundated with. Lost my train of thought. Might have to go to no, so training. Oh, yeah, what's it, exactly?
Inundated. You're obviously inundated
with ideas of that. Yeah. Oh, no, what I was going to say is sort of with the intervention that I was involved with in America, so the LOCI, so Leadership and Organisational Change for Implementation, which has now been applied in multiple projects across the US, and I think it's being looked at in other countries. The idea of that is multiple implementation strategies as a program to have alignment of messages that come down to the providers across the different levels, primarily focused on leadership as the sort of primary target around improving leadership of the first level leaders in an organisation, to help with the providers that have had that training to keep that going, to actually implement it. So that's just sort of one of many different sort of implementation programs that is being studied in implementation science as to sort of what are some strategies that are sort of needed to address all these different factors that influence people's behaviour.
Terrific. Aaron?
Yeah, I mean, I think totally agree that there is no one size fits all solution. And so much of it depends on, you know, how robust an implementation strategy is needed for how complex and how significant a behavior change you're trying to enact. And I think there's actually a lot more work to be done with sort of pairing of implementation strategies to different levels of intervention based on their level of complexity. But so much of it really comes down to identifying and prioritizing, you know, what within implementation we like to call determinants. But until recently, we just called barriers and facilitators until we got tired of that. And identifying what sort of barriers we want to address and which ones are most critical, because any of them can be critical. And we have many frameworks that are, you know, known as determinant frameworks that have many, many different things that could be important, and to one extent or another always are important, but that doesn't mean that it can be prioritized within every implementation effort. So really identifying what those most critical determinants are, and then selecting, you know, if it's a matter of, you know, organizational implementation climate or implementation leadership, bringing something to bear like LOCI that Joe was just talking about, which is a great implementation strategy, and something I actually have a project where we're adapting it for use in schools to promote the implementation of universal prevention programming related to mental health. So I think it really comes down to understanding context and sifting through all the many things that could be relevant and trying to pick out, okay, this is what we think we want to do. This is what we want to try to change. And then ultimately seeing if some of those determinants can be turned into the mechanisms through which your implementation strategy is going to function and have its impact, and figure out, are these determinants malleable? And if so, through what process are we going to change them?
I think that's that's making me think about an additional question, which is also a theme of a number of the questions coming up. And it's a little bit about balancing complexity with getting stuff done. And often behavioral and implementation science, or the application of those in practice, can be seen as extra work. And people can be very overwhelmed and concerned. I thought I'm going to fund some training. Why are we talking about all this extra stuff, So in your experience in Swapna, it got me thinking when you were saying, people kind of talk to us a lot about training, and that by itself, that's not the most effective. How do we as a community or a collaboration work together to help influence people's thinking that sometimes it is more complex and we do have to do more things, but in the long run, we will be better off? Have you got any wise words for us? And I will ask the other two panelists the same thing, but I thought I'd start with you.
So that's tough because, again, I think in Singapore, people are in a rush to get things done. They'll tell you, okay, can you put together some program? We have this funding. Can you put up a proposal and we'll roll it out immediately? And it's hard to kind of, then convince people that, we need to first understand whether it's needed or not, and how are we going to do it? Again, engaging stakeholders. So I think we just have to continue to let them know that, and not rush in to do things without clear outcomes, without clear, KPIs in mind. Because otherwise you kind of, it may not work, and then there's disappointment. So it's always about educating the people, the funders who come to us or who want to put something really fast, especially in the community where there are different people involved. We have to go, there are certain kind of ways on, we have to do 1, 2, 3 before we reach 4.
And having worked a lot in Singapore, I would agree with you on the speed. It's particular. I like it. It's a challenge.
Yeah. So it's good that people are interested, and as I said, more and more people are interested in mental health. So we need to kind of get that enthusiasm and do something to push for more. But we need to do it more systematically.
Yeah, absolutely. So speaking of that, and Joe and Aaron, I'm going to because it's one thing to do a research study with a grant where you kind of have a little bit of, I'm not going to say control, because I know you both work in community settings, but there's a predetermined, they're sort of signing up for. How have you handled trying to influence the sort of training plot, the need for training plus the need for focusing more on the how? And have you got any tips for the audience? I'll start with you, Joe.
I don't know if it's a tip, because it's more that I've experience the same dilemma, or even, you can start with the idea that you're going to do more and somehow you've swung back and you're just training. And that's, a real frustration, where the plan was good and then you've gone back, so there's even that is occurring. Because I also think, to say the term is being used in funding calls to some degree, I don't think it is as much just generally when something comes out as a policy. There's no money being put into implementation at that point. So it's thought of as extra work, but I think it's also thought of as extra money, and it's not getting put in there yet. There's a lot of money being put into mental health in Australia, which is fantastic, but I don't see it yet being some of it being distinctly put aside to fund implementation, which I think would, make a huge difference to addressing only training is occurring. So I think that's sort of my sort of takeaway on that.
Yeah. Aaron?
Yeah, I mean, some of what this makes me think of is how implementation, whether it's implementation research or implementation practice, still seems to have a bit of a marketing problem. Right. And, we like to point to how there's going to be many millions of dollars lost that are going to be devoted to trainings that might be ineffective in actually changing professional behavior. And if we continue to do that, we're not going to see a lot of results for the resources that we're putting into it, and kind of building some, political will in order to make that happen. But there's also the flip side, and making some of our implementation processes, which, as we've noted multiple times today, are very complex and sometimes overly complex, and see what you can do to really streamline them as much as possible. We had a project, now it was a research project, but the goal was really to determine how low can you go surrounding post-training consultation for a practice that we were training school-based mental health clinicians in. We were training them in measurement-based care, and we randomized the different practitioners after receiving the same training to receive different dosages of post-training consultation in order to determine whether it mattered, if they received how much. And we actually didn't find evidence for major differences across dosage groups. Now that was for a relatively simple practice, and that I think takes us back to sort of understanding your context, and your context being both the organization and individuals and innovation that you're putting in place. And that sometimes you can streamline in ways that might not necessarily be the default, at least within the sort of complex implementation thinking that we sometimes seem to fall into.
Mm-hmm. Yes, that is true. So that's why collaborating with policy, practice, and behavioral and implementation science researchers is so powerful, because it does make sure that we are clear, pragmatic in what we do, and useful. So, Swapna, you get the last word here. If you had some advice for BISI as we develop in the Singapore context and look to collaborate with policy and practice, if you had some thoughts that you've some ideas that you've heard today that kind of make you think, oh, that could be something we could try, just give us your what's on top thoughts to finish us off.
Yeah, so Robyn, thanks for inviting me again today, because I learned a lot from just listening to Aaron and Joanna. And I'm just thinking that, there's so much more we can do with implementation science into the clinical services that we put in place, or especially now population health. We are really going upstream into prevention, promotion, and mental health for population. And I think that we need to get this right, because there's a huge investment of money. A lot of people want to get this right. There's a lot of investment in this. So I really feel that we need to put in, get that, study implementation science, understand it, and use implementation science to drive some of these services and measure its effectiveness. Yeah, along the way.
I like that summary. We really need to get this right. That's just a nice way to go. We really do. We don't have a lot of time, and there's a lot of people that could benefit from the very good science that is there to help get to this, what they call post-COVID world, which we're all dying to get to. And just as a side, because there's two of us that live in Australia on this webinar, apparently Singaporeans, may I announce it here ahead of our Prime Minister, will be the first group of people allowed to visit Australia as tourists. So it wasn't, none of the rest of you can't, nobody else, just Singapore. Probably the next couple of weeks will be allowed to come in and spend your tourism dollars. So clearly Australia is looking for you to save us. So please come and get us and take us off this island, because we haven't left for 2 years. All right, thank you, all three of you. Delightful panel. Our next webinar is on the 7th of December, 4 to 5 Singapore time. Really appreciate all three of you joining. I didn't give them much of a brief, so it was brilliant. I thought it was a good mix. And thank you, everybody, for joining, and see you at the next one.